You know that feeling, right? That moment when you're facing just a wave of new information. Maybe it's for a big presentation, or you're trying to make sense of a health update for yourself or someone else. Or maybe you're just, really curious about how things work, how our bodies function. You need to grasp these complex ideas, but quickly, without getting totally bogged down. Well, that's exactly what we're doing here today. We're aiming to cut through the noise on two absolutely fundamental body systems. The respiratory system keeps us breathing, obviously, and the endocrine system, that really intricate, kind of silent network of hormones. We've got a fantastic stack of material here, really packed with crucial insights, stuff ranging from, well, snoring and sleep issues right through to the power of hormones. It's kind of like getting a backstage pass, yeah, to see how our bodies keep us running and, well, what happens when things go a little off script.
It is fascinating, and what's truly striking when you look at the sources is how deeply interconnected these systems are. They don't work in isolation at all. So our goal for you in this deep dive is really to distill the most essential insights. You know, those aha moments, the key warning signs you really need to know. We're taking all this dense medical information and trying to turn it into clear, actionable understanding, something that empowers you, whether you're navigating personal health stuff or just aiming to be, well, exceptionally well informed.
Okay, great. Let's start with something we all do, hopefully without thinking, every single second. Breathing. Specifically, let's explore what happens when the airway runs into trouble, sometimes in ways we might not even realize, like when we're asleep. Our sources really zero in on obstructive sleep apnea, OSA.
That's right, OSA. It's defined by these brief but repeated disruptions in breathing while you sleep. We're talking pauses of at least 10 seconds, maybe up to 5 times an hour, or even more, and it's all because something is blocking the airway.
A blockage.
Yeah, and for someone trying to figure out if this is happening, the single most characteristic symptom, and this is often overlooked, is excessive daytime sleepiness.
Really? More than snoring.
Well, snoring is common, but the profound fatigue is key. Think about it. If your body is literally struggling to breathe, waking you up, even micro-waking you up multiple times an hour, even if you don't remember it, your sleep quality is just shot. That fatigue isn't just feeling tired. It's your body screaming about a critical nightly struggle for oxygen. That's the vital insight here for anyone feeling just persistently wiped out for no clear reason.
Okay, so if someone's constantly exhausted and it's happening unconsciously, how do doctors actually confirm it's OSA? And what's usually causing that blockage you mentioned?
The gold standard for diagnosis is something called polysomnography. It's a comprehensive sleep study. Monitors brain waves, breathing patterns, oxygen levels, muscle activity, the whole 9 yards, all night long.
Right.
As for the cause of the blockage, the major risk factor our sources consistently point to is obesity. Excess weight, particularly around the neck, can narrow that airway when you relax during sleep.
Makes sense. So once it's diagnosed, what are the main ways to manage it? The sources seem to list non-surgical and surgical options, and, well, there looks like a clear order to how they're approached.
Exactly. Non-surgical first, always. That includes lifestyle things like weight loss, which can make a huge difference. Even simple stuff like elevating the head of the bed can help sometimes. But the most common and often really effective non-surgical treatment is CPAP. Continuous positive airway pressure.
A mask thing.
Yeah, the mask. It essentially acts like a gentle air splint. It just pushes air continuously to keep the airway open, preventing those collapses and blockages. And it's really important for you to understand. CPAP is the go-to before anyone starts talking seriously about surgery.
Okay. And surgery.
Surgery, like removing adenoids or reshaping the soft palate tissue procedures like UPPP, they're really reserved for cases where CPAP and other methods just haven't worked or aren't tolerated. They physically alter the airway structure.
Got it. Okay, moving from the sleeping airway, let's talk about the face itself.
Yeah.
Our sources highlight a really crucial distinction with nosebleeds. Epistaxis is the term, right? Anterior versus posterior.
Yes, epistaxis. And this difference is vital. Anterior bleeds, they're the common ones, usually from the front part of the nose. Often you can manage them at home, just simple pressure.
Right.
But posterior nosebleeds, the ones starting deeper back in the nasal cavity, those are a serious medical concern. They're harder to reach, harder to control. They can bleed heavily down the throat. The key takeaway for you is spotting the difference. If a nosebleed is really heavy, if you feel blood running down the back of your throat or it just won't stop with pressure, that needs immediate medical attention. It's potentially an emergency.
Okay, that's a really clear distinction. And nasal fractures. Beyond the obvious, cosmetic issues, what are the big complications we should be aware of?
Well, besides the cosmetic deformity or maybe some airway obstruction from the break itself, a really significant concern with nasal fractures is the possibility of a CSF leak, cerebrospinal fluid.
Wow. Yeah.
Yeah, that indicates the fracture might extend deeper, maybe even a skull fracture, which is obviously much more serious. You might see specific signs like bruising behind the ear, that's called battle sign.
Hmm.
Also, just a practical point, if someone's had no surgery, like rhinoplasty, it's absolutely essential not to remove any nasal packing yourself. That's a job strictly for the surgeon. Pulling it out can cause bleeding or disrupt the healing.
Right. Don't touch the packing. Got it. That makes perfect sense. Now, let's widen the view a bit from just the nose to general facial trauma. Our sources are really clear about the absolute #1 priority in these situations.
Absolutely. Unequivocally, no matter what kind of facial trauma, the first and foremost priority is always, always, always assess the patient's airway. ABC, airway first.
Because of swelling.
Exactly. Swelling, blood, displaced bones, any of these can quickly block the airway, and that's immediately life-threatening. And a critical warning sign that the airway might be closing off is stridor. That high-pitched, almost whistling sound when they try to breathe in, that means air is really struggling to get through the upper airway. It's a major red flag.
Stridor. Okay.
And you mentioned severe facial injuries like Le4 fracture. Those are basically classifications based on how the bones of the face are broken and potentially separated from the skull. Higher numbers mean more extensive, more severe fractures.
Right. Okay, speaking of the head and neck region, let's touch on head and neck cancer. What are the main risk factors we see in the sources? And is there an early sign that should really prompt immediate investigation?
The leading risk factors highlighted again and again are tobacco smoking and heavy alcohol consumption. No ambiguity there. And here's an early sign that often gets missed, but which you absolutely must know. Hoarseness. Specifically hoarseness that lasts for more than 2 weeks. That needs immediate evaluation by a healthcare professional. Don't ignore persistent hoarseness.
More than 2 weeks. That's a clear marker. Now, for some patients with this type of cancer, a total laryngectomy might be the necessary path. What does that procedure fundamentally change for them, especially thinking about speaking and swallowing? And what are the really crucial, maybe even life-altering home care points afterward?
A total laryngectomy involves removing the entire voice box, the larynx. This creates a permanent stoma, an opening in the neck. That stoma is now how the person breathes. So the fundamental change is they cannot speak normally using their vocal cords anymore. There are alternative ways to communicate, like electrolarynxes or esophageal speech, but normal voice is gone. Interestingly, though, their ability to swallow normally is usually preserved.
Okay, that's interesting.
For home care, humidification is key. Because the air is bypassing the nose and mouth, it doesn't get warmed, filtered, or humidified naturally anymore. Dry air can irritate the airway and cause mucus plugs, and here's where daily life changes dramatically. They absolutely cannot swim. Water entering the stoma goes straight to the lungs. It's incredibly dangerous. They also need to use a special shower shield when bathing to keep water out.
Wow. Okay. Big adjustments.
Huge adjustments. And one other point, if you see subcutaneous emphysema, that sort of crackling feeling under the skin around the neck or chest after a laryngectomy, that suggests an air leak and needs immediate attention.
Got it. So pulling these upper airway issues together, what are the most common causes of an emergency upper airway obstruction, regardless of the specific underlying condition? And what are the immediate interventions?
Well, common culprits in an emergency could be the tongue falling back and blocking the airway in someone who's unconscious. Thick secretions they can't clear. Choking on a foreign object. Severe trauma, swelling from infections like epiglottitis. The very first clear sign someone is struggling to breathe, that they're in airway distress, is often an increased respiratory rate. They start breathing faster, working harder.
Trying to compensate.
Exactly. Interventions. They range from simple things like suctioning out secretions or performing abdominal thrusts for choking, all the way up to more advanced measures like inserting an endotracheal tube, intubation, or even creating a surgical airway like a cricothyroidotomy or tracheotomy if the blockage is complete or swelling is too severe.
Okay. Wow. We've really covered a lot on the upper airway. Now let's move deeper down into the chest, exploring lung health, chronic conditions, and some critical care situations. Let's start with asthma. Our sources mentioned the usual triggers, allergens, and smoke and things, but also a couple that might be surprising.
Yes, beyond the common triggers like dust mites, pollen, smoke, or cold air, our sources point out two often overlooked ones. First, aspirin and other NSAIDs, nonsteroidal anti-inflammatory drugs. In some people with asthma, these can actually trigger an attack because they affect certain inflammatory pathways, increasing substances called leukotrienes that constrict airways.
Interesting. And the other one?
The other surprising one is GERD, gastroesophageal reflux disease, acid reflux. Stomach acid coming back up the esophagus can irritate the airways and trigger asthma symptoms, especially at night.
Okay, GERD. Good to know. What about the classic symptoms of an asthma attack itself? And for managing asthma, Dr. Pugsley in our sources really highlights an important distinction with medications.
Classic symptoms include shortness of breath, wheezing, that sort of whistling sound when breathing out coughing, which is often worse at night or early morning, and a feeling of tightness in the chest. And Dr. Pugsley's tip is absolutely crucial. You must understand the difference between controller and rescue medications. It's fundamental to good asthma management.
Controller versus rescue. Okay.
Controller medications like inhaled corticosteroids, think fluticasone, are taken every single day, even when you feel fine. They work over time to reduce the underlying inflammation in the airways, preventing attacks from happening in the first place. They have to be taken daily to work properly.
Right. Preventative.
Exactly. Rescue medications, on the other hand, are things like SABAs, short-acting beta agonists, like albuterol, or sometimes anticholinergics like ipratropium. These are used only when an attack is actually happening for quick relief of symptoms. They relax the airway muscles quickly.
So using your rescue inhaler a lot is a bad sign.
It's a definite sign your asthma isn't well controlled, and you probably need to adjust your controller medication, yeah.
Now, what about common side effects for these? Anything to watch out for?
For the inhaled corticosteroids, the controllers, the main thing is rinsing your mouth out with water after each use. This helps prevent oral thrush, a fungal infection. For the rescue inhalers, like albuterol, common side effects can include feeling shaky or jittery, maybe a tremor, and sometimes a faster heart rate, tachycardia, usually temporary.
Okay. And what happens if someone has a really severe asthma attack and those rescue meds just aren't cutting it?
That is a critical situation called status asthmaticus. It's a life-threatening medical emergency. It means the airways are so severely constricted, so inflamed, that even the rescue inhalers aren't providing relief.
Wow.
It requires immediate, aggressive treatment in an emergency setting. We're talking IV fluids, continuous nebulized bronchodilators, high-dose systemic corticosteroids, oxygen, and very often preparing for potential intubation to take over breathing if needed. It's serious.
Definitely sounds serious. Okay, moving on to another major chronic lung condition, COPD, chronic obstructive pulmonary disease. This includes both emphysema and chronic bronchitis. What are the key differences people should understand between those two?
Right. They often occur together, but they have distinct features. Emphysema primarily involves damage to the tiny air sacs in the lungs, the alveoli. They lose their elasticity, making it hard to exhale fully. This often leads to that characteristic barrel chest appearance and significant shortness of breath. Chronic bronchitis, on the other hand, is defined by inflammation and excessive mucus production in the larger airways, the bronchi. The definition requires a persistent productive cough, meaning coughing up sputum for at least 3 months out of the year for 2 consecutive years.
Okay, destruction versus inflammation and mucus.
In simple terms, yes. And in assessing either condition, getting a detailed smoking history is absolutely critical. Calculating pack years, packs per day, multiplied by years smoked gives a good idea of the exposure.
Right. And when it comes to managing COPD, especially with oxygen therapy, there's a really specific kind of counterintuitive point in our sources.
This is a super important point, often misunderstood. While things like breathing techniques, pursed lip breathing, diaphragmatic breathing can help manage symptoms, oxygen therapy needs careful handling in many COPD patients. Unlike most people, some individuals with severe COPD rely on lower oxygen levels as their main stimulus to breathe. Giving them too much oxygen can actually decrease their drive to breathe. It sounds backward, but it's true.
So less is more sometimes.
In this case, yes. The target oxygen saturation is usually lower, typically aiming for 88% to 92%, often achieved with a low flow rate of oxygen, maybe 1 to 2 liters per minute via nasal cannula. You must be cautious not to over-oxygenate. And of course, the elephant in the room. Smoking cessation. It is without a doubt the single most impactful thing someone with COPD can do to slow disease progression and improve their quality of life. Absolutely critical.
Makes sense. Okay, let's shift focus now to a very serious acute condition, pulmonary embolus or PE. What exactly is it, and what are some of the maybe surprising risk factors beyond the obvious ones like surgery or long flights?
A PE is essentially a blockage in one of the pulmonary arteries in the lungs. It's most often caused by a blood clot, an embolus that has traveled from somewhere else in the body, usually a deep vein in the legs. That's a deep vein thrombosis, or DVT.
Okay, a traveling clot.
Exactly. Risk factors, sure, prolonged immobilization, major surgery, long travel are well known. But others include things like having central venous catheters, pregnancy, obesity, advanced age. And quite notably, our sources highlight COVID-19. It's been shown to increase the risk of blood clots, including PEs.
Wow, COVID-19 too. The sources also emphasize that the symptoms of a PE can be pretty vague. So how do you assess for it, and what's the main goal once it's suspected?
Yeah, the symptoms can be nonspecific. Sudden onset shortness of breath is common, maybe sharp chest pain that worsens with breathing, pleuritic pain, sometimes a cough, maybe even coughing up blood. But it can be subtle, so it's crucial to consider the entire clinical picture symptoms plus risk
We
factors.
put it all together.
Exactly. The primary goal of management, once a PE is suspected or confirmed, is to restore blood flow perfusion to the affected part of the lung and prevent further clotting. This usually involves anticoagulation, medications like heparin, often given IV initially, or warfarin, an oral medication, or low molecular weight heparins, LMWH, injections like enoxaparin.
hmm
These don't dissolve the existing clot, but they prevent it from getting bigger and stop new clots from forming.
And they need careful monitoring, right?
Absolutely critical.
Okay.
Warfarin requires regular blood tests, PTINR, to ensure the dose is therapeutic but not causing excessive bleeding risk. 4V heparin needs monitoring with PTT levels. It's a balancing act. In very severe, life-threatening PEs, sometimes clot-busting drugs, fibrinolytics like Alteplase or TPA might be used to actively dissolve the clot, but these carry a much higher risk of serious bleeding.
So given the risks and potential severity, what's the ultimate best approach to PE?
Honestly, the best treatment for a PE is prevention, recognizing your risk factors and mitigating them. Lifestyle changes like maintaining a healthy weight, staying hydrated, moving frequently, especially during long periods of sitting like travel. For high-risk individuals, sometimes doctors prescribe preventative anticoagulant medication. It really comes down to acting before the clot forms.
Prevention is key. Got it. Now let's talk about the most severe end of the respiratory spectrum. Acute respiratory failure, ARF, and its most devastating form, ARDS, acute respiratory distress syndrome. What defines ARF, and what are those crucial early versus late signs that tell you someone's really in trouble?
Okay, acute respiratory failure, ARF, basically means the lungs can no longer do their fundamental job. Either they can't get enough oxygen into the blood, oxygenation failure, or they can't remove enough carbon dioxide, ventilatory failure, or often both. Doctors look at specific numbers in blood gas tests like PaO2 less than 60, PaO2 greater than 45, SO2 below 90%. But for you, recognizing the clinical signs is key. Early signs are often the body trying to compensate. Things like restlessness, agitation, maybe confusion, a faster heart rate, tachycardia, faster breathing. The person just doesn't seem right.
Subtle at first, maybe.
Can be, but late signs are much more ominous. These indicate the body is starting to fail, it can't compensate anymore. Things like a change in level of consciousness, becoming lethargic or obtunded, maybe cyanosis, bluish skin, a drop in blood pressure. These are signs of impending collapse.
Okay, that distinction between early and late is critical.
Yeah.
And ARDS, what makes it the most severe form, and what's its absolute hallmark sign?
ARDS is indeed the most severe form of acute respiratory failure. It involves widespread inflammation and damage to the tiny air sacs, the alveoli, making them leaky and filled with fluid. And interestingly, sepsis, a severe body-wide infection, is the most common trigger for ARDS.
Sepsis leading to ARDS.
Okay. The absolute hallmark sign of ARDS is refractory hypoxemia. That's a key term. It means severe low oxygen levels in the blood that do not improve significantly even when the patient is given 100% oxygen. The damage is so extensive that the oxygen just can't cross into the bloodstream effectively.
Refractory hypoxemia, got it.
Yeah. And a chest x-ray in ARDS typically shows diffuse, widespread white patches, often described as bilateral infiltrates or having a ground glass appearance. It reflects that widespread lung injury.
Okay. Now, for patients who need longer-term breathing support, we often see either an endotracheal tube ETT or a tracheostomy. What's the main difference in when they're used, and what are some common complications for both?
An ETT, the tube inserted through the mouth or nose into the windpipe, is generally for short-term ventilation. Think days, maybe up to 2 weeks. If someone needs mechanical ventilation for longer than, say, 10 to 14 days, a tracheostomy is usually considered.
Which is the surgical opening.
Exactly. A tracheostomy is a surgical procedure creating an opening directly into the trachea in the neck, where a shorter tube is placed. It's often more comfortable for the patient long-term, makes weaning from the ventilator easier, and allows them to potentially eat and talk sometimes. Complications for both include the tube getting blocked with secretions, the tube accidentally coming out, dislodgement, or potential injury to the larynx or trachea from the tube itself or the cuff pressure.
Yeah, and for someone going home with a trach.
Education is paramount. They and their caregivers need meticulous training on stoma care to prevent infection, how to suction secretions, and the importance of using humidified air, because again, they're bypassing the natural humidification system of the nose and mouth. Preventing complications is the focus.
Right. Okay, let's really dive deep into chest tube management. This seems complex, but obviously vital. Our sources break down that three-chamber drainage system. Can you walk us through what's happening in each chamber and what we should be looking for, or just as importantly, not looking for?
Okay, chest tubes. Their purpose is to drain unwanted stuff, air, fluid, blood from the pleural space, that potential space between the lung and the chest wall, allowing collapsed lung to re-expand. The typical system has three chambers. Chamber 1 is the drainage collection chamber. This just collects whatever is draining from the chest. What you watch for here is the amount and type of drainage. A sudden gush of bright red blood, or maybe more than 100 milliliters per hour after the first hour, could signal active bleeding, and you'd notify the provider immediately.
Okay, drainage amount and color. Got it. Chamber 2.
Chamber 2 is the water seal chamber. This acts as a one-way valve, letting air out of the chest but not back in. You want to see titling in this chamber, the water level gently rising and falling with the patient's breathing. That tells you the system is patent and reflects the pressure changes in the chest. If titling stops, it might mean the lung has fully re-expanded or possibly that the tube is blocked.
So titling is good.
Titling is generally good. It means the system is working and there's still some air or fluid to remove, or the lung isn't fully inflated yet. What you do not want in the water seal chamber is continuous, vigorous bubbling. Intermittent bubbling might happen, especially if the patient coughs or if there's still an air leak from the lung, but continuous bubbling usually means there's an air leak somewhere in the system. Could be the patient, could be a loose connection. Think of it like a seal. You want gentle movement, not constant frantic bubbling.
Okay, gentle titling good, continuous bubbling bad. Chamber 3.
Chamber 3 is the suction control chamber. This regulates the amount of negative pressure or suction being applied to the system. If it's a wet suction system, this is the only place you want to see gentle, steady bubbling. That bubbling indicates the suction is on and working correctly at the set level. You don't want violent, vigorous bubbling. That just means the suction is turned up too high and it's noisy and evaporates the water faster. Think sipping a milkshake gently, not trying to suck it all up at once.
Okay, gentle bubbling only in the suction control chamber. Those analogies really help. Now, what about emergencies? What are the absolute must-know troubleshooting steps if, say, the chest tube completely pulls out of the patient, or if it just disconnects from the drainage system? And is there one golden rule you absolutely should never, ever break?
These are critical situations. If the chest tube comes completely out of the patient, the immediate actions are: first, tell the patient to exhale forcefully or cough. This helps push air out. Second, immediately cover the insertion site with a dry, sterile gauze dressing. Third, and this is key, tape the dressing on 3 sides only.
3 sides. Why only 3?
Taping on only 3 sides creates a makeshift flutter valve. It allows any air trapped inside the chest to escape out through the untaped side during exhalation, but prevents air from being sucked back in during inhalation. Then, obviously, call for help immediately.
Okay, exhale, cover, tape 3 sides.
Yeah.
What if it just disconnects from the system, but it's still in the patient?
If the tube disconnects from the drainage unit, the priority is to prevent air from rushing into the chest cavity through the open tube. So you immediately place the exposed end of the chest tube into a bottle of sterile water or sterile saline about an inch or 2 deep. This creates a temporary emergency water seal. Then reconnect to a new drainage system as soon as possible and notify the provider.
Sterile water is an emergency seal.
Got it.
And the golden rule.
The golden rule you never ever break unless specifically ordered right before removal. Do not clamp the chest tube. Clamping prevents any air or fluid from escaping the chest. If there's still an air leak from the lung, clamping can rapidly lead to a tension pneumothorax, which is life-threatening. So just don't clamp it.
Never clamp. Got it. Loud and clear. Okay, finally, wrapping up respiratory emergencies. Pneumothorax, hemothorax, and the really dangerous one, tension pneumothorax. What specifically sets that tension pneumothorax apart as an immediate, life-threatening emergency?
Okay, so a simple pneumothorax is just air in the pleural space causing some degree of lung collapse. A hemothorax is blood in that space. Both require treatment, usually a chest tube. But a tension pneumothorax is different. It's a true emergency. Air gets into the pleural space, usually through a hole in the lung or chest wall, but it can't get out. It acts like a one-way valve. With each breath, more air accumulates, building up intense pressure inside the chest cavity.
And that pressure causes?
That pressure does two critical things. It completely collapses the lung on that side, and it pushes the heart, the trachea, and the major blood vessels over to the opposite, unaffected side. This shift kinks the big veins returning blood to the heart, drastically reducing blood flow and causing cardiovascular collapse.
Wow. So what are the telltale signs?
The key, almost definitive signs you look for are tracheal deviation. You can actually see or feel the windpipe shifted away from the midline towards the unaffected side and distended neck veins, jugular venous distension or JVD, because the blood can't return to the heart properly. You might also see severe respiratory distress. Maybe one side of the chest looks bigger or doesn't move with breathing. Importantly, cyanosis, the bluish skin, is actually a relatively late sign. Don't wait for that.
Tracheal deviation and JVD.
Got it.
And treatment.
Immediate decompression, usually with a large bore needle inserted into the chest, needle thoracostomy, to let that trapped air hiss out, followed by insertion of a proper chest tube. It's dramatic and life-saving.
Incredible. Okay, wow. We've covered a massive amount on the respiratory system. Huge. Now let's shift gears completely. Let's explore the endocrine symphony, that really intricate, often much more subtle network of hormones that regulates, well, almost everything in the body. What are some of the key, maybe overlooked, assessment cues that might hint at an underlying endocrine issue?
Endocrine problems can be sneaky. They often present with symptoms that seem vague or nonspecific at first. Things you might look for include persistent, unexplained fatigue or weakness, significant weight changes, either gain or loss, that aren't related to obvious diet or activity changes. Also, temperature intolerance. Feeling consistently too hot when others are comfortable or always feeling cold, changes in thirst or how much someone is urinating, and surprisingly, mood swings, irritability, or even depression can have endocrine roots. Hormones deeply influence our mental state.
Right, it's not just physical.
Not at all. And then there are more specific physical signs tied to certain conditions, like the classic moon face and purple stretch mark STRI you see in Cushing's syndrome, or the bulging eyes, exophthalmos in Graves' disease, or the hyperpigmentation, that sort of bronzing of the skin in Addison's disease.
Okay. Our sources also seem to highlight a couple of really big, overarching themes that connect many of these different endocrine conditions, and even a surprising link to recent world events.
Yes, two major themes recur constantly. First, the absolutely critical importance of maintaining proper fluid and electrolyte balance. So many endocrine disorders throw this delicate balance way off, often with dangerous consequences. Sodium, potassium, water, it's central. Second is recognizing the significant psychosocial impact. Living with a chronic endocrine condition often involves major lifestyle changes, body image issues, mood disturbances. It affects the whole person. And the surprising link. Our sources noted how the COVID-19 pandemic was associated with some unexpected endocrine effects. For instance, an increased prevalence of diabetic ketoacidosis in certain groups with type 2 diabetes, and also some disruptions in thyroid function reported post-infection. It just highlights how interconnected everything is systemically.
Fascinating.
Oh.
Okay, let's delve into some specific pituitary and adrenal disorders now, starting with acromegaly. What's the cause here, and what are those distinguishing features someone might actually notice over time?
Acromegaly is caused by the pituitary gland overproducing growth hormone, GH, but typically this happens after puberty, once the long bones have fused. If it happens before puberty, it causes gigantism. So after puberty, the excess GH causes growth in other tissues. This leads to very distinctive features developing slowly over years. Enlargement of the hands and feet, a thickening of facial features, prominent brow ridge and jaw, maybe changes in spacing of the teeth.
It's serious, untreated.
Very serious. A crucial insight from the sources is that untreated acromegaly significantly shortens lifespan, often leading to early death, typically in the 40s or 50s. This is usually due to associated complications like severe cardiovascular disease, diabetes, and hypertension caused by the chronic GH excess.
Wow, okay, early death. That's sobering. Now let's tackle two conditions that sound similar but are opposites. Diabetes insipidus, DI, and SI-ADH syndrome of inappropriate antidiuretic hormone. They both involve ADH, the antidiuretic hormone, right? Start with DI.
You're exactly right. They are polar opposites related to ADH, which normally tells the kidneys to conserve water. Diabetes insipidus is a problem of ADH deficiency. Either the pituitary isn't making enough ADH or the kidneys aren't responding to it properly. That's nephrogenic DI. The result is the kidneys can't conserve water, so patients lose massive amounts of water, producing huge volumes, liters and liters of very dilute, pale urine. The primary concern is profound dehydration and related electrolyte imbalances, especially high sodium levels, hypernatremia.
Extreme thirst and urination.
Extreme. Management focuses on replacing all that lost fluid, often intravenously at first, and giving medication like desmopressin, which acts like synthetic ADH.
Okay, and there's a really crucial, almost counterintuitive warning in our sources about correcting the sodium levels in DI.
Yes, this is vital. Because the body has often adapted somewhat to the high sodium state, you have to correct it slowly. Correcting sodium levels too quickly, especially with hypotonic fluids, can cause rapid shifts of water into brain cells. This can lead to dangerous cerebral edema, swelling of the brain, potentially causing seizures or permanent neurological damage. Slow and steady is the rule.
Slow correction.
Yeah.
Got it. And because it can be a chronic condition.
For anyone with permanent DI, wearing a medical alert bracelet or carrying a card explaining their condition is really important, especially in case of an emergency where they can't communicate.
Makes sense. Okay, so if DI is too little ADH causing water loss, SIADH must be the opposite, too much ADH.
Exactly. SIADH is syndrome of inappropriate antidiuretic hormone. The body produces too much ADH, or ADH is present when it shouldn't be. So the kidneys are told to hold on to water excessively even when the body doesn't need it. This leads to fluid retention, the opposite of DI. The urine becomes very concentrated and low in volume, while the body fluids become too dilute. This results in dilutional hyponatremia, low sodium levels in the blood, not because of sodium loss, but because there's too much water diluting it.
Okay, water retention, low sodium. How's SIADH managed then?
The cornerstone of management is strict fluid restriction, often limiting total fluid intake to maybe 500 to 1,000 milliliters per day. That's really tough for patients. Sometimes medications that interfere with ADH action are used. Hypertonic saline solutions, like 3% ACL, are reserved only for cases of severe symptomatic hyponatremia and must be given very carefully, usually in an ICU setting, because raising sodium too quickly is also dangerous, potentially causing a condition called osmotic demyelination syndrome.
So how do you know the treatment like fluid restriction is working?
Good question. You know it's therapeutic when the urine output starts to increase and the urine-specific gravity, a measure of concentration, starts to decrease, moving back towards normal. And of course, the serum sodium level gradually rises.
Okay, that makes sense. Let's move to the adrenal glands now. Addison's disease and Cushing's syndrome again, seemingly opposite problems, this time with cortisol. Let's start with Addison's. That's not enough cortisol and aldosterone, right? What are the key signs? What's the big emergency we need to know about?
That's correct. Addison's disease is primary adrenal insufficiency. The adrenal glands just aren't producing enough cortisol and aldosterone. Key signs include that distinctive dark pigmentation or bronzing of the skin, especially in sun-exposed areas and skin creases, and also on mucous membranes like the gums. Also, low blood pressure, hypotension, muscle weakness, fatigue, weight loss. The major emergency associated with it is an Addisonian crisis. This is a life-threatening event triggered by stress, like infection, surgery, or trauma in someone with Addison's, or sometimes if they abruptly stop steroid medication. It involves severe hypotension, shock, potentially circulatory collapse. It requires immediate IV fluids and high-dose hydrocortisone.
Okay, crisis is the emergency, and because of the low blood pressure risk.
Because of the chronic hypotension and potential for dizziness or weakness, a key nursing priority for patients with Addison's is implementing fall precautions. Lab-wise, you typically see low sodium, hyponatremia, and high potassium, hyperkalemia.
Low sodium, high potassium. Got it. Now, Cushing's syndrome. That's the opposite, too much cortisol. What are those telltale physical signs, and what become the crucial day-to-day priorities for someone managing this condition?
Cushing's results from prolonged exposure to high levels of cortisol, either from the body overproducing it or, more commonly, from taking corticosteroid medications long-term. The physical signs are quite distinctive, weight gain, but it's often concentrated centrally, leading to that buffalo hump fatty deposit on the upper back and a rounded moon face. Yet the arms and legs might remain relatively thin due to muscle wasting. The skin becomes very thin, fragile, bruises easily, and wounds heal poorly. They develop purple or reddish stretch marks, particularly on the abdomen. They're also highly susceptible to infections because cortisol suppresses the immune system.
Wow, a lot going on there. So what are the key priorities?
Given these effects, the key nursing priorities really focus on safety and prevention. Preventing falls is huge because cortisol excess weakens bones, leading to osteoporosis. Preventing skin injury is vital due to the fragile skin, careful handling, padding, meticulous skin care. Preventing infections is critical because they are immunocompromised, avoiding sick contacts, good hygiene, monitoring for subtle signs of infection, and also monitoring blood glucose as excess cortisol can lead to steroid-induced diabetes.
And a critical point about steroid medications.
Absolutely. If someone is taking corticosteroids for another condition, like asthma, arthritis, etc., they must never stop them abruptly. They need to be tapered slowly under medical supervision to allow the body's own adrenal glands to wake up and start producing cortisol again. Stopping suddenly can precipitate an Addisonian-like crisis. Tapering also helps minimize the risk of developing iatrogenic Cushing's.
Taper, don't stop abruptly. Crucial. Okay, let's talk about surgery involving the pituitary gland, a hypophysectomy. What are the absolute must-know patient teachings and monitoring points, especially given that this surgery often goes through the nose or sinuses?
Right, the transsphenoidal approach through the nose is common. Because of this route and the location near the brain, avoiding any straining that could increase intracranial pressure is absolutely critical post-operatively. This means strictly teaching the patient to avoid forceful coughing, sneezing, blowing their nose, bending over at the waist, or straining during bowel movements, so stool softeners are important. Anything that puts pressure on that surgical site.
Okay, no straining. What else to watch for?
You must meticulously monitor for a CSF leak, cerebrospinal fluid leaking from the nose. Look for clear, watery nasal drainage, especially if it seems excessive or has a salty taste. It might test positive for glucose, unlike normal nasal mucus. Sometimes you can see a halo sign if the drainage drips onto gauze. The clear CSF forms a ring around a central spot of blood. Any suspected CSF leak needs immediate reporting.
CSF leak check. Got it. What else?
You also need to carefully monitor urine output and specific gravity, looking for signs of diabetes insipidus, which can be a complication if the posterior pituitary is affected. And patients need to understand they might require lifelong hormone replacement, typically thyroid hormone and glucocorticoids, if the pituitary gland's function is significantly impaired by the surgery.
Lifelong replacement, potentially, and positioning.
Yes. Keeping the bed elevated, usually 30 degrees, is important post-op. It helps promote venous drainage, reduce intracranial pressure, and minimize swelling at the surgical site.
Okay, good comprehensive overview there. Let's move on now to the thyroid and parathyroid glands. Starting with hypothyroidism, not enough thyroid hormone, seems quite common, especially in certain groups. What are the classic symptoms, and what's the absolute key teaching about its lifelong medication?
Hypothyroidism is indeed quite common, particularly affecting women, often diagnosed between the ages of 30 and 60, but it can occur at any age. Classic symptoms often develop gradually and can include pervasive fatigue, lethargy, unexplained weight gain despite normal or decreased appetite, impaired memory or brain fog, constipation, feeling cold all the time, cold intolerance is a big one, dry skin and hair, sometimes depression.
Sounds like it could easily be missed or attributed to other things.
It absolutely can. Management typically involves thyroid hormone replacement therapy, most commonly with levothyroxine. Synthroid is a common brand name. And this is usually lifelong. The critical teaching point about levothyroxine is how to take it correctly for proper absorption. It must be taken daily, consistently, usually first thing in the morning on an empty stomach, at least 30 to 60 minutes before breakfast or any other medications, and take it with a full glass of water.
Empty stomach, wait before eating. Why?
Food, especially things containing calcium or iron, and many medications like antacids or iron supplements, can significantly interfere with its absorption. So the sources emphasize waiting at least 4 hours between taking levothyroxine and taking those interfering substances. Consistency is key.
4 hours for certain things. Wow. Okay. And is there a severe life-threatening complication associated with untreated or severely undertreated hypothyroidism?
Yes, there is. It's called myxedema coma. It's a rare but extremely serious life-threatening emergency, usually triggered by stress like infection or cold exposure in someone with long-standing severe hypothyroidism. It involves profound lethargy, hypothermia, slowed breathing, low blood pressure, potentially coma. It has a high mortality rate.
And a crucial point about warming them.
Yes, a crucial nursing action if managing someone with myxedema coma and severe hypothermia is to warm them slowly and passively. Using warming blankets is okay, but rapid active rewarming, like immersion baths, must be avoided. Rapid warming can cause dangerous vasodilation, potentially leading to cardiovascular collapse. Slow and gentle is key.
Slow warming. Got it. Okay, now the flip side. Hyperthyroidism and overactive thyroid. What are its hallmarks, and what's the corresponding life-threatening emergency here?
Hyperthyroidism, or thyrotoxicosis, is due to excessive production of thyroid hormones, T3 and T4. Symptoms are often the mirror image of hyperthyroidism. Think heat intolerance, feeling hot and sweaty all the time, palpitations or a racing heart. Increased appetite, but often with unintentional weight loss because metabolism is sped up. You might also see nervousness, anxiety, irritability, tremors, difficulty sleeping. And in Graves' disease, the most common cause, you often see exophthalmos, those bulging, protruding eyes.
Heat intolerance, weight loss despite appetite,
Okay.
and the emergency.
The life-threatening emergency associated with hyperthyroidism is thyroid storm, also called thyrotoxic crisis. It's an extreme, exaggerated state of hyperthyroidism, often triggered by stress, infection, or surgery in someone with uncontrolled hyperthyroidism. It's characterized by a dangerously high fever, hyperpyrexia, extreme tachycardia, very rapid heart rate, potentially heart failure, agitation, delirium, coma. It's a medical emergency requiring immediate aggressive treatment.
High fever, extreme tachycardia. Got it. And the immediate goals.
Immediate objectives are to rapidly reduce the high body temperature, using cooling blankets, Tylenol, not aspirin, control the dangerously high heart rate, often with beta blockers, provide supportive care, and address the underlying cause. Preventing cardiovascular collapse is paramount. A key caution mentioned in the sources: avoid salicylates like aspirin because they can actually increase levels of free thyroid hormone, worsening the storm.
No aspirin and thyroid storm.
No.
Okay. Then we have hypoparathyroidism, which affects calcium levels. What are the most important signs that indicate critically low calcium? These sound quite dangerous.
Hypoparathyroidism usually occurs due to accidental removal of or damage to the tiny parathyroid glands located behind the thyroid during neck surgery, like a thyroidectomy. These glands regulate calcium levels. Without enough parathyroid hormone, PTH, calcium levels in the blood drop, hypocalcemia. Low calcium makes nerves and muscles overly excitable. The key signs relate to this neuromuscular irritability. Think tetany, involuntary muscle spasms, cramping, twitching, numbness and tingling, especially around the mouth and in the fingertips and toes.
Tetany, numbness, tingling.
Yes. But two critical assessment findings that specifically test for this latent tetany are Trousseau's sign and Schwastek's sign. You must know these. Trousseau's sign is elicited by inflating a blood pressure cuff on the arm above systolic pressure for a few minutes. A positive sign is carpal spasm. The hand and fingers contract involuntarily into a characteristic posture. Schwastek's sign is checked by gently tapping the facial nerve just in front of the ear. A positive sign is a twitching of the facial muscles on that side. Seeing either of these is a critical indicator of significant hypocalcemia needing urgent treatment, usually with IV calcium.
Trousseau's and Schwastek's. Critical signs. Okay. And speaking of thyroidectomy, what are the key post-op concerns besides potential hypoparathyroidism?
Besides hypocalcemia from parathyroid damage, the other major immediate post-op complication after thyroidectomy is hemorrhage or hematoma formation in the neck. Because it's a very vascular area, bleeding can quickly compress the airway, which is an emergency. So careful monitoring of the neck dressing, checking for swelling or difficulty breathing is crucial. Preoperatively, a key goal is actually reducing the patient's stress and anxiety to help prevent triggering a thyroid storm if they were hyperthyroid before surgery.
Right. Prevent storm pre-op, watch for bleeding, and low calcium post-op. Makes sense. Okay, let's wrap up our endocrine deep dive with diabetes mellitus. Hugely prevalent. We need to clearly understand both low glucose, hypoglycemia, and high glucose, hyperglycemia. What are the crucial red flags for low glucose, and what's that immediate intervention everyone really should know?
Hypoglycemia is a potential medical emergency. Low blood glucose starves the brain of its primary fuel. Symptoms can come on quite rapidly. Early signs include feeling shaky, sweaty, diaphoresis, anxious, maybe palpitations, hungry. If it progresses, you see more neurological symptoms: confusion, dizziness, blurred vision, slurred speech, fatigue, lack of coordination. If not treated, it can quickly lead to seizures, loss of consciousness, and potentially permanent brain damage. It's serious.
Okay, shaky, sweaty, confused. So what's the rule for treating it?
It's crucial for anyone with diabetes, their families, and even the general public to know the 15-15 rule. If blood glucose is measured and found to be low, typically defined as less than 70 mg/dL, though individual targets vary, the person should consume 15 grams of fast-acting carbohydrates.
Like what?
Like 4 ounces, half a cup of juice, or regular soda, glucose tablets, read the label for 15-hour dose, or hard candies. Then wait 15 minutes and recheck the blood glucose. If it's still low, repeat the 15 grams of carbs. Once the glucose is back in range, they should eat a small snack containing protein and carbs if their next meal is more than an hour away to prevent it from dropping again.
15 grams. Wait 15 minutes, recheck. Simple but vital. What if they're unconscious?
If the person is unconscious, confused to the point they can't safely swallow, or having a seizure, do not try to force food or drink. That's an emergency requiring immediate medical help. Treatment would involve either an injection of glucagon, which stimulates the liver to release stored glucose, or intravenous IV dextrose administered by healthcare professionals. And one important concept is hypoglycemic unawareness. Some people, especially those with long-standing diabetes, lose the ability to recognize those early warning signs of low blood sugar, making episodes much more dangerous because they don't treat them promptly.
Unawareness. That sounds risky. Okay, and for the other side, hyperglycemia, high glucose, what are the most common signs people might notice?
Signs of hyperglycemia tend to develop more slowly than hypoglycemia. The classic 3 Ps are often mentioned: polyuria, frequent urination, as the kidneys try to flush out excess glucose; polydipsia, increased thirst due to the fluid loss from urination; and polyphagia, increased hunger, as the body cells aren't getting the glucose they need for energy. Other common signs include blurred vision, glucose affects the lens; dry mouth, fatigue, slow-healing sores or infections. And if hyperglycemia becomes severe and progresses towards diabetic ketoacidosis, DKA, you might notice a distinct fruity odor on the breath.
The 3 Ps and fruity breath. Okay, now, there's a really clear and important distinction between type 1 and type 2 diabetes, both in what causes them and in the extreme hyperglycemic states associated with each. Can you break that down?
Absolutely fundamental distinction. Type 1 diabetes, which often but not always starts in childhood or young adulthood, formerly called juvenile onset, is an autoimmune disease. The body's immune system mistakenly attacks and destroys the insulin-producing beta cells in the pancreas. So people with type 1 have an absolute lack of insulin. Their pancreas produces little or no insulin at all, therefore they always require insulin therapy. Injections are pumped to survive. It's not preventable. And type 1 is classically associated with the complication diabetic ketoacidosis, or DKA.
Absolute insulin lack requires insulin associated with TKA.
Got it. Type 2. Type 2 diabetes is much more common, historically developing in adults, adult onset, though we're seeing it increasingly in younger people now, often linked to obesity. In type 2, the primary problem is usually insulin resistance. The pancreas does produce insulin, at least initially, sometimes even producing extra insulin. But the body's cells don't respond to it properly, they resist its effects. Over time, the pancreas may also gradually lose its ability to produce enough insulin. Management starts with lifestyle changes, diet, exercise, weight loss, and oral medications that improve insulin sensitivity or help the pancreas release more insulin. Some people with type 2 eventually need insulin therapy as well, but not always. And type 2 is associated with a different hyperglycemic emergency called hyperglycemic hyperosmolar syndrome, or HHS.
Insulin resistance, maybe later decreased production. Lifestyle oral meds first associated with HHS. Okay, clear difference. And when we talk about long-term diabetes complications, the sources mention macrovascular versus microvascular. What's the difference there?
Good distinction. It refers to the size of the blood vessels affected by chronic high blood sugar. Macrovascular complications involve damage to the large blood vessels. Think atherosclerosis, hardening of the arteries, accelerated by diabetes. This leads to increased risk of major cardiovascular events like stroke, high blood pressure, hypertension, and heart attacks, myocardial infarction. Big vessel problems.
Stroke, heart attack. Okay. Microvascular.
Microvascular complications involve damage to the small blood vessels. This affects specific organs. Think retinopathy, damage to the tiny vessels in the retina of the eye, which can cause blurred vision and lead to blindness. Nephropathy, damage to the small filtering units in the kidneys, potentially leading to kidney failure. And neuropathy, damage to nerves, often starting in the feet and hands, peripheral neuropathy, causing numbness, tingling, pain, and contributing to foot ulcers and slow-healing wounds. It can also affect autonomic nerves, leading to things like sexual dysfunction or digestive problems. Small vessel problems with big impacts.
Eye, kidney, nerve damage from small vessels.
Yeah.
Okay, let's touch on those hyperglycemic emergencies again. DKA mostly in type 1 and HHS mostly in type 2. What are the key features that really distinguish DKA?
DKA, diabetic ketoacidosis, is a serious complication primarily of type 1 diabetes, though it can occur in type 2 sometimes under severe stress. The key features are: 1. Hyperglycemia, usually blood glucose over 250 or 300 milli-GDL. 2. Ketones present in the blood and urine. This is crucial. Because there's no insulin to let glucose into cells, the body starts breaking down fat for energy at a rapid rate, producing acidic byproducts called ketones. 3. Metabolic acidosis, the ketones make the blood acidic. It usually develops relatively quickly, over hours to a day or two. Patients often have symptoms like nausea, vomiting, abdominal pain, and that characteristic deep, rapid breathing called Kussmaul's respirations, which is the body's attempt to blow off excess acid as CO2. And the fruity breath odor is due to the ketones. Treatment involves aggressive 5e fluid resuscitation to correct dehydration, a continuous IV insulin drip to stop ketone production and lower glucose, and careful electrolyte replacement, especially potassium.
Ketones and acidosis are key for DKA. And HHS, seen more in type 2, how does that present differently?
HHS, hyperglycemic hyperosmolar syndrome, is also life-threatening, but typically occurs in people with type 2 diabetes, often older adults, maybe with an underlying illness or infection, and frequently associated with profound dehydration due to inadequate fluid intake over time. The key distinguishing features of HHS are: 1. Extreme hyperglycemia, often much higher than in DKA, frequently over 600 mg/L, sometimes even over 1,000. 2. Severe dehydration, leading to very high serum osmolality, meaning the blood is extremely concentrated. 3. Critically, there is minimal or no significant ketoacidosis. Because people with type 2 usually still produce some insulin, it's often enough to prevent the massive fat breakdown and ketone production seen in DKA. HHS typically develops more gradually over days or even weeks. Neurological symptoms like confusion, lethargy, or coma are often more prominent due to the extreme hyperosmolality and dehydration. Treatment is similar in principle to DKA. Massive fluid resuscitation is paramount, along with insulin therapy and electrolyte management, but the focus might be even more on rehydration initially.
Extreme glucose, extreme dehydration, but no ketones for HHS. Got it. That's a really helpful comparison. And finally, just a quick but important practical note from the sources on insulin dosing and types. It can seem like a really complex landscape.
It can be, with all the different names and types. The key thing to grasp is that insulins are categorized mainly by how quickly they start working, onset, when they peak, and how long they last, duration. You have rapid-acting insulins, like Lispro Aspart, taken right before meals to cover the glucose rise from food. Short-acting, regular insulin, taken maybe 30-60 minutes before meals. Intermediate-acting, NPH, which lasts longer, often taken once or twice a day. And long-acting or basal insulins, like Glargine and Detamir, taken once or sometimes twice daily to provide a steady background level of insulin throughout the day and night. Mixing insulins is sometimes done to reduce the number of injections, a critical detail to remember. Regular short and NPH intermediate insulins can be mixed in the same syringe. Clear before cloudy is the rule for drawing them up. However, long-acting insulins, Glargine, Detamir, generally cannot be mixed with any other insulin type in the same syringe, as it can change how they work.
Clear before cloudy for regular and NPH. Don't mix the long-acting ones.
Got it. Wow. Okay. We have just navigated an incredible amount of essential ground. Seriously deep. From the immediate mechanics of breathing and those critical life-saving interventions, right through to the intricate, often really subtle symphony of our hormones. What truly stands out to me from this whole deep dive is just how connected seemingly completely different health issues actually are, and how absolutely vital it is to recognize those early warning signs, especially those must-know moments we talked about that signal a real emergency.
Absolutely. And whether you dove in today to get a better handle on a specific condition that affects you or someone you know, or maybe just to satisfy that powerful curiosity about how our bodies work, our real hope is that you now feel much more in the know. Remember, being well-informed isn't just about, memorizing a list of facts. It's really about seeing the bigger picture, understanding why certain details genuinely matter for your health and for understanding the health of the people around you. Yeah, absolutely. And we kind of connect this to the bigger picture. Think about how many of the emergencies we discussed today, right? From something like a thyroid storm to a tension pneumothorax, even a posterior nosebleed. They share this profound common thread: early recognition. Spotting it early is the absolute key to preventing really severe, maybe even life-altering outcomes. So it kind of raises an important question for you listening right now. In this world that's just overflowing with complex information, what seemingly small, must-know detail in your own life or your own health knowledge could, maybe with a bit of a deeper dive, reveal an unexpectedly critical insight. Something to think about.